And that's a great introduction to some of the things that we're going to be talking about next. And for example, I'm going to spend a little bit of time as we go through some of this information putting some of the things in perspective. For example, frequently you heard Dr. McArdle say, this is an adverse prognostic factor. It's worse to have this than that. What does that mean? Okay, and we're gonna actually talk about a few numbers today in statistics, because I find that very frequently patients ask, well, what are exactly my chances? What are the exact odds that you'll find something in a lymph node or not? And one of the things I always say is that you're not a percentage of a person. You're not a statistic. You're an individual. It's an all or nothing for any one person. You could have many factors that say this looks really bad, and yet with melanoma, people still can do very well. And occasionally we see the opposite. Every factor seems to point to a good outcome, and something bad happens. Melanoma is one of the most unpredictable types of tumors that we treat. And we absolutely, if we don't start with a good analysis under the microscope, we're lost to begin with. But even if we do, we find a lot of other curveballs along the way. We're going to talk about some of those. So when I show you numbers and percentages, I want you to pay some attention to a few things. You'll see as I show you some of the numbers that what might happen in 5 years might be favorable, and yet after 10 years, some bad things could still happen, okay? I do wish I had a nickel for every patient who said, my doctor only gave me 6 months to live, and I'm still here 10 years later. I'd be doing pretty well, because melanoma is very unpredictable. But also, sometimes people hear things differently. So we'll show you some numbers that are like the median or the average. So somebody might say, what are my chances of living 5 years? And we might say, well, the average patient only makes it 2 years, okay? Does that mean I said you have 2 years to live? No. How many of you consider yourselves perfectly average in every way? Raise your hand. Dr. Weber's the only one who raised his hand. But most of us aren't average in any way, let alone in every way. Okay? And what an average or a median number, especially median, literally means is this is what will happen to 50% of the people, and 50% of the people will pay no attention to that. We'll do much better than that. That's why I wish I had a nickel for everybody who said, my doctor only gave me 6 months to live, and I'm still around. Because half of the people who thought that they were given 6 months to live will do better than that. So I could get a nickel from every one of those people. Okay? As long as I didn't have to give a nickel back to the other half, I would come out ahead. All right? So we're going to talk about how I take that data that Dr. McArdle has given us and how many decisions we really make off of that data and what we do with it and what it means, what this information means. First of all, a little background about all types of skin cancers. Skin cancers are basically today the most common kind of cancer that people in the United States and in most of the world suffer from. More than 1.5 million cases in the U.S. this year, and the sun is definitely not any of our friends. And the kinds of cancer come from the different components of the skin. The basal cells of the skin, let me see if I can go back one. Yeah, this is normal skin. There's no cancer in this, but it's pointing out the different kinds of cells. The basal cells, the squamous cells, and with the little white around them in this picture, the melanocytes. And each of those turns into a particular type of cancer if it becomes cancerous, if it has the genetic changes that occurred that Dr. McArdle mentioned, this loss of some genes, activation of other genes, that we'll come back to when Dr. Weber speaks to you about how we can figure out now, in some cases, what gene is mutated and occasionally actually do something about it for the first time in our careers. So that's an extraordinarily exciting aspect of taking care of melanoma and even basal cell cancers now. There are some new drugs that could attack some of the genetic changes. But the basal cells, if they go bad, we get a basal cell cancer. Squamous cell cancer. But if the melanocytes go bad, we get a melanoma, and that tends to be the toughest one to treat. 1 out of 5 Americans will probably get skin cancer in their lifetime today, and it's even higher in Florida, and we don't have good numbers about most forms of skin cancer because most people just have them taken off in the dermatologist's office. It's not even counted in most of the national databases. But it's melanoma that we're mostly here to talk about. I sometimes call it the killer skin cancer because of all those 1.5 million cases that are of skin cancer that occur in the United States, only about 10 to 11,000 skin cancer deaths occur total. And of that 10 to 11,000 skin cancer deaths that occur in the United States, over 8,000 of them come from melanoma. So even though melanoma is only a small fraction of the total number of cases, a little more than 100,000 new cases were expected in 2009, and we're waiting for the 2010 figures, and only half of those cases or so were really invasive melanoma, and about 5,000 a year in Florida, but over 8,000 deaths in the United States. So about 4 times as many deaths from melanoma as all other kinds of skin cancer combined. Still, most people with melanoma don't die from melanoma, okay? Dr. Weber will go more into this. Melanoma, we now believe increasingly, is many different types of problems, and it may be different if it occurs on your scalp or your foot, or if it's pigmented versus non-pigmented, if it's on your fingernail, if it occurs in an area that doesn't get a lot of sun exposure, or one that gets a constant sun exposure, or one that just got a few sunburns when you were a kid, like maybe your back. And these many different diseases have many different genetic mutations that are now coming to be their signature, and we're trying to exploit them and target some of those individual genes, and Dr. Weber will talk about that. Melanoma tends to be a disease of intermittent sun exposure that comes in the area not where you get heavy sun exposure and you're darkly tanned, and not in an area where you've had no sun exposure, but right at the edge, like in this outdoor worker who wore a heavy work shirt, but depending on where his collar was, some days he'd get a lot of sun right at the edge of his collar and get a sunburn. Other days he wouldn't get any sun and didn't get the protection that he had on the head. Now he'll get skin cancers of basal and squamous type there, but he got a melanoma right here at the red zone, we call it. So now let's talk about surgery. We use the information from that pathology report to plan our surgery and to decide what to do next. How much surgery to take, how much of an excision to take around the normal skin around the melanoma to make sure we do the best chance of getting the roots of that melanoma out. And we use it to decide whether or not to do a sentinel lymph node biopsy, abbreviated here. And we are particularly interested in trying to figure out which very early melanomas, less than 1 millimeter in thickness as measured under the microscope, should have a sentinel node biopsy, and we'll come back to that in a minute. So how many, just out of curiosity, how many people in this room had a sentinel node biopsy at any point in their melanoma treatment? And I see a lot of hands up, a lot more people than consider themselves average. Well, the sentinel node biopsy procedure is based on the knowledge that every piece of skin has its own little lymph node that's connected to it, and that we can map these. We can make a map from the original site of the melanoma by injecting a blue dye or a radioactive tracer and see which lymph node turns blue or shows up on the scan. And it's going to be a different node for every different part of the body, and some parts of the body might have 2 nodes or 3 nodes even in different parts of the body, and not everyone is exactly where we would expect it to be. So we do an injection prior to surgery. The white circle here was where the melanoma was, and a little shield placed on there and the outline of the patient as they lie on the table, and these black dots right here are the two sentinel nodes with the lymphatic flow flowing right into that sentinel node in both armpits. Now these nodes turn black for the same reason they turn blue, simply because the lymph node filters everything out that we inject into that lymphatic space, not because there's cancer in there. It's just a road map. It doesn't tell us whether anyone's gone down that road or not. It just tells us which direction the melanoma would be most likely to head, where would be the most likely first resting spot it would reach. Okay? With that knowledge, we can make a very small incision and find the little blue channel going right into the blue lymph node. And if we take out this lymph node, and even only this part of the lymph node is the most likely part of that lymph node that we're going to find cancer under the microscope. And this is a lymph node. Dr. McCardle didn't show you a lymph node. These cells don't look like the melanoma cells he showed you because they are actually stained with a particular stain. I think this is S100 is what it's called. But they're stained with a stain so that actual individual cancer cells would show up as different from the normal cells within the lymph node. So you can literally see that in this lymph node, you can pretty much count 1, 2, 3, 4, 5, 6, maybe 7 individual cancer cells were spotted in this sentinel lymph node. And that's as early as we can pick up metastatic melanoma. Okay? We try to do this sentinel node and pick it up at that stage, not at this stage, which is a huge tumor in the lymph nodes, which has gotten into the skin, okay, and causing a very large recurrence in a patient who didn't have their lymph nodes biopsied or checked originally, not for any reason other than that the sentinel node biopsy procedure wasn't invented when this patient originally had their melanoma surgery. So I told you I'm going to tell you some numbers. What does this mean? What does it mean when we say it's a good prognosis, it's a bad prognosis? And you'll see it's not an exact science. From a large study of sentinel node biopsies, we know that the sentinel node status, whether it's positive or negative, is the single most important prognostic feature, the single most powerful predictor. How do we tell that? We tell that with these hazard ratios or risk ratios. These numbers tell us that if your sentinel node is positive, you're 2.5 to 3 times more likely to die if you have melanoma in your sentinel node than if you do not, if your node is negative. And that's more significant statistically than the thickness, whether the melanoma is ulcerated, than Clark level, than any of the other factors that they measured in this study. So let's look at that 2.5–3% times. What does that mean? And show you some numbers. Here's a big update to this study that just came out. Over 700 patients who had a melanoma in this sort of medium category, and 122 of them, about 15–16%, had a positive sentinel node. At 5 years, 90% basically were alive if the sentinel node was negative, 70% if the sentinel node was positive. By 10 years, a few more people had died in both groups, so 85% alive if the sentinel node was negative, 61% if the sentinel node was positive. To a statistician, highly, highly statistically significant. But to a patient, they have to realize that even if their sentinel node is positive, still have a better than 50-50 chance of living 10 years free of death from their melanoma. So even though that patient is 3 times more likely to die than another patient, they still wouldn't be necessarily more likely to die from melanoma in 10 years. They would actually be less likely than a 50-50 chance. Flip a coin, okay? So it's important to understand it's a serious prognostic factor. It's not a death sentence, nor is the absence, the negative factor, a proof that the melanoma would never come back. Let's take a look at a few more numbers. Here's thicker melanomas. Same thing. Even with a thick melanoma, if the node is positive, the outcome drops about 20% at 5 and 10 years, and the hazard ratio about twice. But notice with a thick melanoma, even if your node is negative, you're a little bit more likely to die. That's why we say, even despite the sentinel node being negative, having a thicker tumor is an adverse prognostic factor, but not a death sentence, even if the sentinel node is positive. With the thin patients, it's really interesting, and this is another point I want to make. Notice that at 5 years, if you have a thinner melanoma, they picked 1.2, we would consider less than 1 to be a really thin melanoma. Only 10% of the patients had a positive node. And at 5 years, there's almost no difference in whether you had a positive or a negative node, because it was picked up so early that nothing has happened for the first 5 years for most patients. But by 10 years, the patients with a negative node still have an extremely good prognosis, but the patients with a positive node, 30% of them have died of melanoma, even though it was picked up very early. Still favorable that it was picked up early, still highly adverse that even at that early stage it had gotten into the lymph nodes, 4 times more likely to die with a thin melanoma if your node is positive than if it's negative. So these are the kind of numbers I want you to understand, so that you understand that while it's relatively worse, it's not always absolutely awful, and vice versa. It may be relatively better, but it's not always absolutely perfect. Okay? And sentinel node, what does it do? Now that's the prognosis. What does it actually do for people? Well, one thing the sentinel node does that I think it does very, very well is it keeps you from showing up like that patient in that picture with a big lump under the arm. Not perfect, again, but very, very well. So people who had a sentinel node biopsy were more likely to go without another relapse, another reoccurrence for longer, because that lymph node metastasis had been taken out. In most cases, there was still, some of the people still had another recurrence beyond the lymph node. The sentinel node didn't necessarily prevent that, but it might have in perhaps a few people. But if you take everybody, just whether you have a sentinel node or not, and sometimes people kind of agonize, should I go through the sentinel node biopsy procedure or not? Mostly, for most patients, this is not a life and death kind of thing. You see here that at 5 and 10 years, people who did and didn't have a sentinel node, basically very, very, very similar chances of being alive 5 and 10 years later. If we are keeping an eye on you and watching your lymph nodes and deal with them when they do become enlarged promptly, your outcome is the same. You may not have that predictive information at your fingertips, but for most people, actually whether we take out the sentinel node or not isn't a life or death thing. But the question is, what if your sentinel node is positive? And let me, before I get into that important question, let me backtrack and cover one other topic here on this slide. How often is the sentinel node biopsy falsely negative? Okay, this is a very important question. And this study that I'm showing you the data involved 2,000 patients from all over the world. In fact, about half the patients were from Australia and only about a quarter from the United States. So a very average for the whole world. We would like to think here at Moffitt we do a little bit better. But of all the people that they told had a negative node on the sentinel node biopsy, by 10 years, almost 5%, more than 4% of them, showed up with a lymph node anyway. So the test was only about 95.5% accurate for telling the lymph nodes were truly negative. Our results, after many years of working on this, a little bit better than that, but still, a couple of percent of the people who are told their lymph nodes are negative still come back. This chart here tells what percentage of all the positive nodes are actually missed. And it's a higher percentage because not everyone has a positive node. Most people have negative nodes. And you see that about 12 to 18% of positive nodes in this international study were actually missed. The more nodes, the more likely there is to be a positive node. Well, the more likely, if you happen to take out the wrong lymph node, that there's something in the other lymph node and it will show up. So the higher the risk of the melanoma to begin with, the more likely that false prediction may come true, but actually statistically it's equally likely to be correct or false regardless of the type of melanoma to begin with. So there's an error rate associated with sentinel node biopsy that we have to understand. Now this is what I was talking about. What's the impact? Let's say we could know your lymph node was positive without ever taking it out. What would be the impact of leaving it there versus treating it early with surgery? And this study shows that it suggests very, very strongly that if you leave the lymph node that's positive behind, it's worse than if you deal with it early on. That patients were a little bit more likely to survive 10 years if they had a positive sentinel node and immediate surgery, 56%, versus if they had a positive lymph node that showed up over years of observation. And that was particularly true if the melanoma was kind of in the intermediate category. If the melanoma was thick, it didn't matter so much whether they had an early treatment or not, presumably because those people where the melanoma was going to spread more widely, it had already occurred, so it wasn't that it was too late to do any good with surgery, but it was too late to change whether or not the melanoma had metastasized simply by surgery alone. Okay? A few more little tidbits about why we are very eager to do surgery early rather than later, because we think the side effects of surgery are less if we do them early rather than later. Okay? And in this study, there were a couple of hundred people who had their lymph node dissection completed immediately after the sentinel node, 130 people who had a lymph node surgery after they came back with a positive lymph node years later. The people who came back later had more total number of lymph nodes that had cancer in them and had a slightly higher rate of wound dehiscence, that's separation of the wound, seromal fluid collection under the wound, similar rates of infection, and actually dysesthesias, which is nerve sensations in the wound, were more likely if you had the earlier surgery, because we actually spared more nerves. Your wound wasn't as numb if you had it. Okay? But the most important discovery was that the people who had the surgery earlier had less swelling, less lymphedema in their arm or their leg if they had it early rather than having it later, 12.5% versus 20.5%, and that was a very important observation and one we'd seen ourselves. This just shows that we also didn't see that the type of lymph node dissection in the groin had any impact on how likely you were to have swelling. So to summarize about this, what we've learned from this MSLT melanoma sentinel node study, even as we've continued to follow these patients, sentinel node status remains the most important predictor of survival for melanoma, whether your melanoma is thin, medium, or thick, as long as it's thick enough, greater than that 0.76 level that Dr. McCardle mentioned. Sentinel node biopsy detects small metastases, which if we did nothing about them, would eventually show up as a lump and need to be dealt with. And it decreases, because of that, it significantly decreases the number of people who have to come back for a second surgery. But it misses the right lymph node a small percentage of time, and 4.5% of people who are told their node is negative have to come back and have surgery on their nodes anyway. And the evidence to us continues to indicate that patients with a positive node benefit from that earlier surgery, both in terms of a little bit better chance of survival and with less swelling and other problems from their lymph node dissection. There's still some important questions we have to answer. How much of the benefit is just from taking out the sentinel node? How much is the benefit from taking out all the remaining lymph nodes? A couple of people in this room, I think, are participating in a second study aimed at looking at exactly that, where we flipped a coin and heads took out all the lymph nodes, tails were keeping an eye on them after a positive sentinel node. That's going to be a very, very important study. And can we go beyond the microscope eventually and use all these molecular diagnostic techniques to find melanomas even earlier in the lymph nodes? And that's the next study that we're talking about. The last thing, just we have another couple of minutes before the break, I want to talk and transition to lead into what Dr. Weber is going to talk about. Because increasingly we do surgery not just for the earliest stages of melanoma, but now for the latest stages of melanoma, for metastatic melanoma. And this is a patient who had a melanoma that had spread to their intestinal tract, and we were in there to remove it. And in fact, the melanoma, when we go back there, had spread from the intestine to one of the lymph nodes in the intestine. So the metastasis had metastasized to another lymph node nearby. So there are certain strict criteria we use, but we do occasionally operate on people with metastatic melanoma. Why do we consider it? What are those criteria? Well, we want to use our scans because PET scans, CAT scans have gotten much better and allowed us to select the people who really just have one or a few areas that we can remove and have a chance of getting control of the melanoma for a period of time. We like to think, and I think there's a lot of reasons to believe, that we do better, our patients do better after surgery, with a much better chance of getting through surgery unscathed than they used to have. In some cases, through scopes and other minimally invasive techniques. And we have to admit that up until recently, we haven't had a lot of great excitement about some of the treatments for metastatic melanoma with chemotherapy particularly, that have led people to look for any available alternative. And there have been people who've done very well for many years after surgery. So who should have it? We think only people with truly isolated, recurrent, or metastatic melanomas with a whole body PET scan, a CT scan, an MRI of the brain, or in rare cases like somebody with a blocked intestine when there are direct symptoms from the tumor. Pretty much we don't discriminate by site in terms of which site of the melanoma we would operate on, with the exception that in the liver, results of actual surgery are not as good, and the risks of surgery on the liver are pretty high. And that's spurred us here and at several other places around the country to study an alternate way of treating melanoma when it's only in the liver, called hepatic perfusion. PHP, my colleague Dr. Zager has been studying this. We're one of 3 places in the country that have been doing this on an ongoing basis, where a catheter is put right up into the liver, balloons are inflated so that chemotherapy can be blown right into the liver and not into the rest of the circulation. And this is looking to be a very favorable approach for melanoma in the liver. We're waiting for a major study of that to be analyzed, and we hope by the end of this year maybe to have some data that this might be a new and widespread approach to use when melanoma gets to the liver instead of surgery or other forms of chemotherapy. So we think there's a light at the end of the tunnel. We think people are doing better with melanoma, even metastatic melanoma. We also think it's very important to avoid making the mistakes of the past. The name of this boat, this unfortunate boat, is the Temporary Insanity 2. We can only speculate on what happened to the Temporary Insanity number 1. But we're trying not to make the mistakes of the past as we go forward into the future. And one of the mistakes that we think in the past, you may hear this from Dr. Semino as well, is that people got too focused on their own little world, their own silo. It's all about surgery. It's all about chemotherapy. It's all about pathology. And we want to work together as a group, and that's one of the things we've been very, very committed to here at the Moffitt Cancer Center. We have an outstanding team of people I'm very fortunate to work with, and I'm glad you get a chance to meet some of them that you might not already. If you want more information about our program and about future symposiums like this and our new our quarterly newsletter that we're starting, you can join our email list by just sending an email to Cutaneous Oncology, cuteonc@moffitt.org, or you can sign up. Lois will have a list outside.